The remaining unmet medical needs in relapsed refractory myeloma, and I would broaden it to all of myeloma, are really three. First, being elderly frail. We know that these patients still do worse. When you look at their overall survival curves, the curve is not flat from the very beginning. Secondly, renal dysfunction. Patients with renal dysfunction still have, in many studies, inferior overall survival. And the third are high-risk patients. Those are the three groups of patients that are bringing down the median overall survival for myeloma. So if we can improve their outcomes, the median OS of this cancer will get even better.
As we see all these new drugs emerging on the horizon, I think a big question comes up about what are the continuing unmet needs for many of these patients. And I think that a lot of that is beginning to be segmented. We know, for instance, that patients with standard risk disease can do quite well. And again, in our series, 70% of them are alive at 10 years. And so the question becomes, where do we need additional input? I think that patients with plasma cell leukemia or extramedullary disease continue to remain a challenge at the time of diagnosis. Patients with early relapse, meaning relapse within a year of transplantation, those continue to remain a challenge for us to manage. And patients with other high-risk genetics continue to remain a challenge for us where they don't have that 70% 10-year survival. And so optimizing ways to manage them, utilizing our agents in the most rational way to try and get them to MRD negativity, all of those remain unmet medical needs in myeloma.
There are still very significant unmet needs for treatment of myeloma, especially in relapsed refractory disease. So we are in a continuous race and search to not to be put in a position that we come to the patient room and we have to tell the patient that we have exhausted all the possible regimens and drugs, and we at the moment have nothing to offer. This is a terrible moment for not only patient but also for those who treat. These are most difficult moments for me as a treating physician, and I would rather not have them. That's why I'm so heavily involved in trying to develop new drugs and regimen. And that is the unmet need which we have in our hand. We have more and more patients who are quad refractory for both most active drugs in a given class, proteasome inhibitor and IMiD, and penta, which will be with antibody, also refractory. And this is the population which I mentioned earlier is eventually allowing selinexor to be potentially considered as next approved drug, because this drug works in this group of patients. This is clearly unmet need. In my opinion, another very important unmet need is to try to selectively treat patients with certain abnormalities or risk factors, cytogenetic risk factors. We have tools and we can potentially implement them and use them more effectively if we are using our knowledge about the biology of the disease and about the drug and potentially matching those two. So this is unmet need. We need more research, and that research is in progress or is about to start. My discussion about how to treat the patients is my emerging for now, not now, but for some time, optimism that not only that we are doing better, but that we are potentially having opportunity and potentially in the near, very foreseeable future in next 2, 3, maybe even less years, that we can have strategies which can cure the proportion of patients with ability to say that we cured. At the moment, we presume that we cured some patients who are 10 or more years in remission and have not required treatment for many years to come. We worry that some of them, and rightly worry, may be relapsing later on, but at that fraction of patients who are achieving that durability of responses is where my optimism is based. I think that some of the best strategies bring proportion of these patients in long-standing remission to such a high proportion that I can really be sharing that enthusiasm with you. 60 to 70% of patients achieving with some strategies complete response in MRD negativity, which is predicting and in fact showing longer remission and survival, is truly fantastic achievement.
What I'm excited about seeing in myeloma are more personalization. I think we treat this disease as one entity, and that's because under the microscope it looks like one entity, but we know that these patients are not all the same, and we need to go towards a lymphoma type of paradigm where we treat low-grade lymphomas with a different approach than intermediate grade and high grade. I think we have those similar categories in myeloma. We just haven't been able to segment patients yet well enough to do randomized clinical trials that personalizes this approach. We also need to be, I think, thinking about who needs therapy for how long, and can anybody be discontinued? Because we already know that about 10% of patients don't relapse in 10 years, and that's functionally cured. And yet, right now, we couldn't tell, and so everybody's getting treated to progression. If we could identify these functional cures and discontinue therapy, that would be great for patients to have a long treatment-free interval. And I would say the third category is really the heavily treated patients. So we are still losing patients every day to this disease, and I think we really need these novel agents. The compounds and strategies that we've discussed today, like the GSK compounds, selinexor, CAR-T, which are the most promising and have all gotten some kind of breakthrough designation from the FDA. Hopefully some of these agents will help with that segment of population.